So we continue with urine concentration and dilution. The flow through the Vasa recta along with the flow through the tubules in the absence of, this is in the presence of antidiuretic hormone, and before this was in the absence of antidiuretic hormone. We left it there, actually not there, we left it at what is the osmolality of the fluids at the end of the proximal tubule. The whatever filtrate has been formed, it is isoosmotic with the plasma. So for the purpose of understanding concentration and dilution, or what we have known as the countercurrent mechanism since our, so first we assume that if there was nothing, only the anatomical structure, the loop, and there would be nothing except this anatomical structure, this loop, if there would be no transport proteins, that means mechanism for renal reabsorption and secretion, if there wouldn't be any mechanism, then whatever would be filtered would go out through the tube and it would have no purpose. Actually, this loop would have no purpose. It would be simply an anatomical structure, a pipe through which the filtrate is formed and it goes out as urine. Because the mechanisms of reabsorption and secretion are there, and also whatever could not be filtered, and the second point is whatever would not be filtered had no chance to go out. Okay. So if there was no transport mechanism, so in that case what would happen? So this is a very rough picture, as we have seen some rough pictures from the maybe textbooks or internet, whatever we are showing over here. I have not made any one of them. So they have shown just the tube. How should we draw it as? After the straight part of the proximal tubule, actually the limb is, this part is, actually we should draw it, this part as thin, this is the thin descending limb, and this part as thin ascending limb, and then maybe thicker, this is the thick ascending limb. Like this we should draw it. Now what were the characteristics? You weren't there yesterday, 98 ছিলে না, কি ক্যারেক্টারিস্টিক ছিল, কোথায় কি অ্যাবজর্পশন হচ্ছে মনে পড়ছে? একদমই মনে পড়ছে না, তাহলে তো খুব মুশকিল। এটা তো কালকেই ক্লাস হয়েছে, কোন পার্টে কি হচ্ছে সেটা তো মনে পড়তে হবে। থিক অ্যাসেন্ডিং লিম্বে কি হচ্ছে? অ্যাক্টিভ সোডিয়াম ক্লোরাইড। So this is the part. So if you don't remember just from yesterday, it is, you have to think what you will do. But this is the part where we showed thick ascending limb, active NaCl transport, and permeability to all else. Permeability means diffusion. Maybe diffusion may be simple, may be facilitated, that is permeability. Permeability of the cells in the thick ascending limb is virtually, this is practically zero. That means nothing, neither water nor the solutes are going out through the, neither water nor solutes are being transported there. But see again, note this down. In the thin ascending limb, it is somewhat permeable to NaCl, but not to water. So where does water go? Where is water reabsorbed? Thin descending limb. So the thin descending limb in the concentrating portion of the tubule. But there is no such term we use as such. But the diluting portions of the tubule must be the ascending limb. As ascending limb water permeability is 0, but actually we take it the thick ascending limb. Water is no absorption and there is active NaCl absorption, much of NaCl absorption. So that is the diluting, means the tubule, fluid inside the tubule is being diluted. This is the primary event which we consider for explaining the countercurrent mechanism. Countercurrent mechanism, this is the primary event. So, active NaCl transport or active NaCl absorption out of the thick ascending limb, and also water absorption through the thin descending limb, these two. So, again if we just redraw it, I am not drawing the con. This part is the proximal convoluted tubule. Okay. And now thin, loop, thin, again thick, and here will be the, this part is the early distal tubule. Others we had leveled just now. That part is early distal tubule. So, early distal tubule is just the early part of the distal tubule. And why? What is the speciality of, anatomical speciality of that part? What are the cells present there? Ekdom in vicinity to the early distal tubule. Actually, all these drawings are for the, all these images are for the sake of understanding. Actually, what happens? This part, when the U-shaped loop, it is going near the, if here is the glomerulus, it will go near the glomerulus. Usually for clearer depiction, the glomerulus is drawn over here, but actually glomerulus is over here, and this is turning, and the distal tubule, early part of the distal tubule is near the, if we have repeated it I think at least 50 times, that it is near the, near what? Near the efferent arteriole of the same nephron. Both afferent and efferent, more near the efferent. Near both. Actually, these are so tiny structures, these are actually near both. So, there are the which cells? Macula densa cells. So, that is a separate thing, means that is macula densa cells. What they do? They sense NaCl, act like chemoreceptors. These have been discussed. But that is the EDT. Thick descending limb and early part of the distal tubule, no water reabsorption, even if there is ADH, whatever may be there, highest concentration of ADH, there is no mechanism to reabsorb water. So, it is called the diluting segment. But what happens up to this part? This is the EDT. What happens up to this part? 290, 300, whatever you write, approximate. What is that? What is 290 or 300? So, this is the 290 to 300 milliosmoles per liter or per kg, whatever, osmolarity per liter, or if it is osmolality per kg. That is the plasma osmolality. So, at the end of the proximal tubule, in reality it is 300. But here it is not so. For the purpose of discussion, beginning the discussion on the countercurrent mechanism, we are assuming it is 300 as if there is nothing, no physiological mechanism for reabsorption or secretion. But actually, when we consider there is active NaCl transport but no water transport, what will happen? 300 will come down or go up. There is NaCl is going out of the tubule, water is not going out. So, it is being diluted. So, the osmolality will increase or decrease. Tell this at least. It will decrease. Obviously, it will decrease. So, we may directly write it as 300. Keeping it as 300, we may increase the, just an increased value of the medullary interstitial fluid just behind the ascending tubule. But to make it more simple at the beginning, we consider it becomes 200 and it becomes 400. It can be direct written as 300, 500 because of the mechanism. But first we write it as it becomes, one becomes 300 to 200, another becomes 300 to 300 is also, if we assume there is nothing, no transport going on, then everything, the medullary interstitium is also 300. But medullary interstitium, as soon as NaCl goes out, it becomes 200, it becomes 400. And what immediately happens is that, I should have drawn it a little bit clearer. What immediately happens is that this is a ongoing process. This is an ongoing process. That means it does not, as soon as it is once it has been established, whatever we discuss, once it has been established, the countercurrent mechanism, it goes on forever. Physiologically, if the kidneys fail, there is some problem, there is some issue, then that is something. Physiologically, it goes on like forever. So immediately here is also, it is also 300 first. Then what? But what can be in this part? What can go out? See this thin descending limb. Permeability of water is much. Active transport is not occurring. Active NaCl transport, but permeability to water, NaCl. Forget urea for now. Everything is water and NaCl. Both are there, but water is more than NaCl. So water will be reabsorbed, and this 300 will try to come in equilibrium with this. So this becomes 400, and for this instant, consider this remains 400. But what will happen as soon as this becomes 400? This is actually 300, not assuming. At the end of proximal tubule, it is actually 300. It is again flowing. So all over this part, this is 300 has become 400, and it is being equilibrated, and this 400 is going up here, and then it is repeated. Do you get it? At the end of the proximal tubule, it is actually 300. It is not just imagining, but rest we have imagined. As there are transport proteins, active NaCl transport, primary, the medullary interstitium, if there was no transport mechanism, everything would be 300, 290 to 300. That is, we are writing as 300. As soon as this 300 becomes 200, this becomes 400, this equilibrates, this is happening all over here. But immediately what happens? This fluid comes down, and whatever has become 400 goes up, water has become, and all this fluid moves in the forward direction. Means here, whatever is forward, downward is forward, or upward is forward in the ascending limb, upward is forward. So what happens? Now this is 300, say up to this point it is 300 now, because this has come down and this has pushed up. Now this 400, okay, I just did not mention one thing, the capacity of the tubular reabsorption and whatever is occurring. In the thin descending limb, some NaCl permeability is there, whatever is occurring, see this table, whatever is occurring, they have just not written the early distal tubule. In the early distal tubule, there will be water is also 0. In the early distal tubule, take it, whatever is written in the thick ascending limb, just add a line between thick ascending limb and distal tubule, that is, write this as late distal tubule, and in between add early distal tubule and write the characteristics of thick ascending limb, and early distal tubule same. Do you get it? Thick ascending limb, early distal tubule same, just add one line, and whatever is written as distal tubule, write it as later part of the distal tubule. What I just forgot to mention is the maximum osmolar difference due to the primary active transport in the thick descending limb which can be achieved is 200. Okay, we just wrote 300 becomes 200, and 300 in the interstitium fluid becomes 400. This is the maximum which can be achieved. If we break it down, you can think it as 300 first becomes say 270, and 300 in the medullary interstitiums becomes 330, then 300 becomes 250 in the tubule, and that 300 becomes 350, and maximum that is achieved, that is 400. This is difference. What is the difference? 400 minus 200 at first. This is the maximum. It cannot go above that. Because of what? Because it is impermeable to water, but it is permeable to other solutes. So this is, we are mainly considering the transcellular mechanism. Mostly transcellular is 50 to 60%, and paracellular is in between the cells, what we call tight junctions. Again, just recollect it. So see, NaCl is going in between the cells also. So this is paracellular. So there is some paracellular diffusion. So ultimately, comes back, goes out, whatever is happening, the maximum that can be achieved is 200. Now in the second step, second, third, whatever you call it, when this has gone, when 400 from here has gone over here, now again there is, when it has reached in the thick part, again due to the primary active transport, there will be a 200 difference. So whatever was 300 will become 500, whatever was 400 will become 600. Like this it will go on, and the descending limb, whatever is happening in the descending limb, that is only relatively permeability of NaCl is there, but much more permeability of water, and it will try to equilibrate with the medullary interstitium. So after few cycles means we are just imagining it is now continuing in the body. After once it has been established, what medullary concentration is established? This is, as we saw it, it will be highest, it will be 600 if no ADH is there. But remember one point, at the tip of the loop of Henle it will be 600, but no ADH is there. Does ADH act on the loop of Henle? No. So what is mentioning, what is actually controlling the medullary interstitium? Osmolarity. Not only this loop of Henle countercurrent loop, but also if there is ADH, whatever happens in the collecting duct is also contributing to it. Whatever happens in the collecting duct. And for those, first note down these characteristics, we just come back. In the collecting duct, if there is ADH, it is water permeable. If there is no ADH or very less ADH, it is not water permeable. But NaCl permeability is 0 and active NaCl transport is there to some extent. Some extent means to a considerable extent, which is shown by 1 plus sign, but not like the thick ascending limb. It is much more. So these are the characteristics of the late distal tubule. They are writing collecting tubule, or you say collecting duct, or cortical collecting tubule and medullary collecting ducts. Whatever is the medulla, that is surely the collecting duct, but whatever is in the cortex, maybe the part, if it is a part of the that nephron, it is the collecting tubule. If the nephron has already drained into the collecting duct, it is the collecting duct. This is what is happening in early distal tubule. Still it is water impermeable, like the thick descending limb, a thick ascending limb. There is nothing called the thick descending limb, sorry. So if I just make these types of mistakes, which is, just correct me, tongue, when I see my own classes, there are some few mistakes which I edit. Like yesterday I told, what is the characteristic over here? This is not about urine concentration, glucose reabsorption. What thing about glucose reabsorption differs in the first half of the proximal tubule? This is the first half of the proximal tubule. This is the second half. Glucose reabsorption is not shown, but what is the thing differing? The presence of SGLT2 in the first half, SGLT1 in the second half. But yesterday, by the slip of the tongue, I just mentioned it is about GLUT2. GLUT2 is not, that is not different. Difference is SGLT2 and SGLT1, and most will be reabsorbed in the first half by SGLT2. So this is in the early distal tubule, this is the thick descending limb. This is reabsorption and secretion, which have been discussed. Reabsorption and secretion, thick portion of ascending limb. So this was the summary. That's okay, we are coming to it. So this is what is in the absence of ADH, it becomes 1000. So this is what is, so this space and this space is same. Again, it is going over here near the afferent arteriole, very tiny structures. This space and this space is actually same, not different. So this, whatever is happening here is contributing to the medullary interstitium osmolarity as well. And although this is labeled as in the presence of AVP, it is 1200 in the AVP is arginine vasopressin. ADH is also written as AVP because there are two forms of vasopressin we know, arginine vasopressin, lysine vasopressin. In human it is arginine vasopressin. So whatever we discussed, this is, say again, in the absence of ADH. Absence means nothing is totally absent, but just we consider it is not good enough to. So ADH acts on this part, late from this part, early distal tubule is this part, where the red dot is now, and compare what is over there, that is the early distal tubule. So late distal tubule, collecting ducts, or the cortical collecting tubule and medullary collecting ducts. So here the ADH should act, and here it is not acting. When ADH is acting. So what is the highest concentration of urine achieved in humans? What is possible? It is 1200 to 1400. It is much more in rodents like say mice, much more. The capability as great as 10,000 milliosmoles per liter. But in humans it is 1200. So highest diluting capacity of how much times of plasma osmolarity? 4 to 4 point something, 1200 to 400. But what is the diluting capacity? This is, here it is not labeled, 50, 30, so almost 10 times, 8 times, 10 times, 8 to 10 times. Diluting capacity, quantitatively diluting capacity is much more than concentrating capacity in case of human beings. So this is what we discussed just now, that gradually repeating the steps, and it has already been established. What is over here? First we consider it as 300 all over, then primary ascent, what is happening in the descending limb, again they have not, in this picture thin and thick are not distinguished, but this arrows show active NaCl transport, and then this is shown water permeability. Wherever they are showing diffusion, the dotted lines, wherever they are showing active transfer energy mediated, that is the straight lines, not the dotted lines. So these are active NaCl transport, this is diffusion. So now this fluid is coming down, this 400 is going over here. Again, as there is no water absorption, 400 tends to become 300, but immediately NaCl is transported, and what will be the 400 becomes 300, 300 becomes 500, and as the steps are repeated, gradually this increases. At the tip it is 1200. So is it in the absence of ADH, or when ADH is there or not there? When ADH is there, but ADH does not act on this descending ascending limbs, loop of Henle. ADH acts over there. Okay, so that is also a contributory factor, very important. But we are now concerned countercurrent mechanism, as it is countercurrent mechanism named because of fluid is flowing in opposite direction after the loop. So that is Vasa recta also, that is also, but that is not called countercurrent. Whatever we come to the discussion of Vasa recta, so if this thing, whenever it is happening, and here the Vasa recta is shown, this is about urea, we will come to it, we will just coming to it. Vasa recta is shown. This also, what do we see in the Vasa recta? Solute going inside in the descending limb, water going out. Then as the direction is reversed, these processes are also reversed. And as these processes are reversed, what is happening? If if instead of the Vasa recta being a counter current, if the Vasa recta will be straight, this is a loop, but if the Vasa recta will be anatomically straight and it would go out without forming this loop, like the loop of Henle, what would happen? The solute and water reabsorption or diffusion outside inside will be only in one direction. Then what would happen? Solutes going out, solutes going in, because the medullary interstitium is still hyperosmotic because of whatever is happening inside the tubule. That thing, this thing, whatever is happening here. So the medullary interstitium is hyperosmotic, and blood is coming. Blood is 300 inside. Vasa recta is coming blood, so 300. So solutes will go inside, water will go out, and if it is straight, Although the loop of Henle, whatever is happening in the nephron tubule tries to maintain the medullary osmolality, blood washes it away. Blood washes it away because blood is 300, the plasma osmolality is 300. So it washes it away, and the medullary interstitium, this concentration, this whatever is required, medullary interstitial component for the countercurrent mechanism, this will dissipate away. If the Vasa recta is straight, if the Vasa recta is not looped like the loop of Henle, if it does not follow like the loop of Henle, Vasa recta are straight tubules, but at some point it will form the loop, has to form the loop and follow this thing, even if exactly not at the same level. This is for just for depiction, but at some point it has to follow the loop, otherwise it will dissipate the medullary interstitium concentration, whatever is achieved by the loop of Henle by the nephron. If the adjoining blood vessels do not support it, then it will be dissipated away. So in this, so that's why Vasa recta are also called, it is not called the countercurrent multiplication. Countercurrent, whatever we are calling countercurrent, is called countercurrent multiplication. One after another it is increasing. That is what is happening in the loop of Henle. But what happens in the Vasa recta? It is called the countercurrent exchange mechanism. Because just solutes and water are just exchanged. Any backup? It is the countercurrent exchange mechanism, right? Countercurrent multiplication and countercurrent exchange. This is what is the method of urine concentration and dilution, but what will happen in the collecting ducts? What will happen in the collecting ducts under ADH? Not only water, and now we should discuss what is the primary. We have considered primary solute for all these, primary solute for concentrating the medullary interstitium, NaCl, but there is also urea. Now urea, when we can come to this chart, urea is not, some urea transporters are there in the loop of Henle, ascending and descending limbs, some are there, but mostly they are present in the collecting ducts, okay, mostly in the collecting ducts. And which portion of the collecting ducts? Medullary collecting ducts. If the collecting ducts start in the cortex itself, then also at the level of the cortex there are no urea transporters. ADH acts not only for water reabsorption in the presence of ADH, not only water reabsorption but also urea reabsorption. Water reabsorption under the influence of ADH starts where? In the late distal tubule, and it continues down the collecting ducts or cortical part of cortical collecting tubule, whatever you call it, and the medullary collecting ducts, but urea is only in the medullary portion, that means very deep portion of the kidney, medullary portion of the collecting ducts. So down 50. Medullary portion of the collecting, so urea reabsorbed medullary portion of connecting ducts, and some is in the late distal tubule and the late distal tubule and cortical portion of the collecting ducts or cortical collecting tubules, no urea transport. Urea transport is in the either in the loop of Henle or in the medullary collecting ducts. So you see, this is shown as percentage of filtrate. These figures are shown as percentage of filtrate. In the proximal tubule 100%, and in the proximal tubule, also in the proximal tubule, obviously proximal tubule everything is, most solutes are transported. Glucose 100%. Come back to this one. No need to remember all the figures. So whatever is glucose is 100% and 100% is in the proximal tubule. Urea is in different parts. Ultimately 15% goes out, 50%, but that is also absence or presence of ADH. The values are not same. So primary, we can just show this once before. Urea is not written, so you can add urea to this. So it is variable. In other parts it is written variable. And just note it down once again, at the end of the PCT tubular fluid is isotonic to plasma. At the end of the loop of Henle, as well as it should be written, actually it should be written at the end of the early distal tubule, tubular fluid is hypotonic to plasma, because in that part, thick ascending limb and early distal tubule, water cannot go out, it is hypotonic, and tubular fluid leaving the collecting tubules or the collecting duct, actually it should be written, is dilute when ADH level is low and it is concentrated when ADH level is high. Now what happened? So what about urea? In the proximal tubule, 50% is, this is filtered road remaining. But what happens? 50% is again secreted. Where from it is secreted? So today it is disturbing, okay. Where from it is secreted? Some is secreted in the proximal part of the, in the thin ascending part. So just write it down, even if you cannot see the pictures, just write it down. Urea is secreted in the, so if the image is in front of the eyes, then it is difficult. You should write down, I mean you should note it down. We cannot learn how to take notes when you have come to become a graduate. This should be learnt in school. You should write down the salient points even when the image is there, because all these images you can't read so many textbooks together. You will read only one, maybe maximum 2 books. So all these things, most of the salient things will be mentioned, but you should have your own, whatever you compare it with your notes. So urea reabsorption in the collecting duct. Urea reabsorption in the collecting ducts, if ADH is there and some of it is secreted through the, whatever is secreted into the loop of Henle, which portion? Thin ascending portion. So again the concentration is increased. The filtered load, it will match the filtered load, but that is not because of the filtration. Most was reabsorbed in proximal tubule. Some, whatever is now reabsorbed in collecting duct goes into the loop of Henle. Very small amount, like 5%, is carried away by the blood through the Vasa recta. But urea, most is recycled. It goes out through the collecting duct, reabsorbed, then again secreted into the loop of Henle, and these, there are no urea transporters in the loop of Henle. Which part? Thick ascending part. Thick ascending part, early distal tubule, late distal tubule, cortical part of collecting ducts or cortical collecting tubule, no urea transporter. So this is recycled again up to the medullary collecting ducts. Again reabsorbed. This recycling is going on. So role of urea is in maintaining the medullary interstitium concentration is by recycling of itself, but it is under ADH. If ADH is not there, not only water impermeability, that is water will not be reabsorbed through all these, where are the aquaporins, late distal tubule, cortical collecting duct, not only water, but this urea recycling will also stop. So without ADH, it is, urine becomes dilute. Whatever medullary concentration is there, interstitial medullary osmolarity or osmolarity is there, it is concentrated, but ADH, without the ADH, urine can't be concentrated, it will be dilute. This urea recycling won't be there also. Again, whatever is going 55%, so 100%, 50%, 100% remaining. So this is, some urea transporters are there, nothing, almost nothing, but 30% reab, so 70% remaining. Most is here, most is here. So if it is 55%, if you don't have to remember these values, percentage values you don't have to remember. You just remember if there is ADH, then only 15% of urea goes out. But in that image where there was that table, it was 50%. That is in the absence of ADH, 50% goes out. But if there is ADH, this happens and this recycling occurs, and 15% of what was the filtered load. You don't have to remember this, just you will face the, from the examination point of view, you will face the question as role of urea in the maintenance of this medullary medullary interstitium osmolarity and the countercurrent mechanism. Role of urea. So one question is direct question. There are seldom now these days there will be direct questions. Write about the urine and concentration and dilution mechanism. There will be parts of it. Either describe what happens in the, not describe what happens in the, how is the countercurrent mechanism formed, or what is the role of urea, what is the role of Vasa recta. So in the, it is the role of Vasa recta, you have to write it is not countercurrent multiplication, but it is countercurrent exchange. Just the solutes and waters are exchanged in the different parts, in the descending part and the ascending part of the Vasa recta, that is just exchange, not multiplication. So if the loop of Henle, the events in the loop of Henle does not occur, Vasa recta has nothing to do. But even in the presence of the events in the loop of Henle, without the Vasa recta, that cannot be maintained, that will be dissipated. This medullary interstitium osmolarity will be dissipated. Whatever concentration is achieved, that is dissipated, and role of urea is through the recycling, it is maintaining, it is helping. Even if urea is not there, so more urea, the concentration ability of the urine concentration, more urea, more there is the filtered load of urea. These are showing in percentages, but think of an absolute figure, filtered load of, again think of an absolute figure. This is without ADH, gram per day, filtered load is 56 gram per day, and it is going out 50, it is in the absence of ADH, not with ADH. So 56, how can it be increased? How can the filtered load be urea be increased? Can we control the kidney from outside? Will we inject urea? Will we inject urea? So from your, how is urea formed? From the knowledge of biochemistry, you should tell better than me. Protein metabolism. So urea is increased. The question should not be can be increased. Like there was a question last time, how can the voluntary strength of muscles be controlled? So I discussed these things whenever we got a chance. So there should be, that is the voluntary means something has to be done from outside. Some of the students showed like we will increase calmodulin, we will increase this and that. Firstly, calmodulin is not associated with skeletal muscles, it is associated with smooth muscles. But that cannot be, that is a very, very stupid answer, because that cannot be done from outside. To increase urea, your aim is not increasing urea, but how is urea increased? If there is more protein in the diet, simple answer. So if there is more protein in the diet, whatever happens, there are goods and bad sides of it. Very high protein is again not, but the kidney's concentrating ability is increased. That is for sure, because of this, whatever mechanism urea contributes to the concentrating mechanism, whenever there is more urea, concentrating mechanism of which is achieved under the influence of ADH is increased. So again, see this thing, just very important, but you can just understand where the urea concentration is going on increasing. Concentration in the interstitium. When in the inner medulla it is, why is it a straight line? Cortex and outer medulla, here the urea transporters are not there very much. It is starting maybe in the middle part of the outer medulla or the inner medulla mostly, it is going above. But NaCl is uniform. Permeability, active transport is not there. Active transport is not there in the, again recheck, active transport, that means there, it is to a less extent, but diffusion is not there, but active transport is there. So NaCl, but it does not increase in the medullary collecting duct than the late part of the distal tubule or the cortical part. So it will be maintained, or concentration throughout the late distal tubule collecting duct, it is not very much increased, but what is increased very much? Urea. So it is 0 in distal tubule and cortical collecting tubule or collecting ducts in the cortical part, but in the medullary collecting part, under the influence of ADH, urea transport is maximum. So this concentration adding to the interstitial osmolarity, solutes will add to the interstitial osmolarity. This is high in the medullary interstitium part, in the inner medulla, this part. But NaCl is more or less not very much increased from the other portions, from the earlier portions. Do you get it? এটা তোমাদের কোথাও আঁকতে হবে না, কিছু করতে হবে না, just you understand it. This will be happening because this again depicts to you that urea reabsorption is mainly in the inner medullary collecting duct and some is in the loop of Henle we showed in the earlier secretion. 5% is, this is removed. Whatever is reabsorbed, most is again secreted into the loop of Henle and some is removed, washed away by the, washed away means it is returning. It is returning. Washing away means whatever enters the kidney through the renal artery can leave either through renal vein or through the urine. There is no, in the absence of any structural not malformation, it is, so there is something tear away of the tubules or something, then it accumulates in the tissue spaces. We are not considering such pathological condition here. Physiologically, either it should go out through the urine or it has to come back to the blood through the renal vein. So this 5% removed means to the Vasa recta means it is coming back to the circulation. This is we have discussed. Hypothetical, if the hypothetical countercurrent exercise is real, but what is hypothetical? If this would be straight, the mechanism it could not maintain. Loop of Henle mechanism could not. Whatever is happening in the loop of Henle, the interstitial osmolarity would be dissipated away if it would be straight. As it is looped, then only countercurrent. This is the Vasa recta, not the loop of Henle. This is the Vasa recta itself. This is a hypothetical straight one. So as it is looped, then only what is happening? This interstitial osmolarity is being maintained as the countercurrent. So this is just the summary. If you can write it down in 2 minutes, you may do it. Just read it. Active, step 1 is active NaCl reabsorption. Step 1 which we consider, just our consideration for the sake of understanding the counter. This has been discussed over and over again. Discussed means this has been researched over there. What may be the contributing factor for the countercurrent mechanism? Okay, এটা দেখো দাদা, এটা দেখুন মানে কিছু জুম করে আনা যায় কিনা। আসে না খুব একটা, আমি তো ভিডিওগুলো দেখছি, এই স্লাইডগুলো আসে না, দরকারও নেই আসার। কিন্তু active NaCl reabsorption without water in the thick ascending limb makes the tubular fluid more dilute and the interstitium concentrated. This is the first step we are considering. Second step is the fluid in the descending limb equilibrates osmotically with the fluid in the interstitium. সেটাই তো এটা hyperosmotic interstitium by movement of water out of the tubule through water channels, and that is AQP1. There are 13 AQPs in that part. There is AQP1. Now the concentrated fluid in the descending limb will go down, flows counter current up, the first go down, then up the ascending limb. Why are you laughing? কি হচ্ছে হাসার মতো কি হচ্ছে? Where NaCl is passively reabsorbed, further concentrating the medullary interstitium. Obviously, again it will show. Now the cycle has started. Then water is reabsorbed in the cortical and outer medullary collecting ducts. Urea concentration in the tubular fluid rises markedly. Urea concentration in the tubular fluid. How? First reabsorbed, then again secreted. Urea then moves passively out of the inner medullary collecting ducts into the interstitium through vasopressin regulated UT and UTI3, UT1, UT3. If you don't remember, it is okay. Those are in the medullary collecting ducts. And what is in the loop of Henle? It is UT2. UT1 and 3. Urea transporter 1 and 3 in the collecting ducts, medullary collecting ducts. UT2 in the loop of Henle for urea. Urea contributes to increasing the interstitial osmolality, but even without urea it can be achieved. But without ADH it cannot be achieved. Without the hormone ADH it cannot be achieved. But even with less urea it can be achieved, lesser than what is if there is considerable urea, or if it is more urea, more protein, high protein diet, more urea, more concentrating ability. The Vasa recta have a hairpin configuration similar to the loops of Henle. It is in close proximity to the tubule and plays a key role in the maintenance of medullary osmotic gradient by returning the NaCl and water reabsorbed to the systemic circulation. Returning the, what is written? I also did not read this. By returning the NaCl and water reabsorbed to the systemic circulation. Yes, there will be some return, but you don't write that last line. You write it is the countercurrent exchange. In the ascending, descending part of the limb, don't write that last part. Even if you write returning NaCl, yes, it is true, but what we should concentrate on here, but what we should emphasize here, that whatever solutes and water, whatever movement direction in the descending part of the Vasa recta, ascending part it is just opposite. That's why it does not allow it to be dissipated. Don't write this. You write plays a key role. These are non-specific things to write, but hairpin configuration like a U shape, this you write. The U shape is same like the loop of Henle as it is in the tubule. That is the loop of Henle. Now clinical application. What do you mean by diabetes? So what types of diabetes have we heard of? Anything except diabetes mellitus? It's diabetes insipidus. Why is it called mellitus? Why is it called insipidus? Either most terms are, which is Greek, which is Latin, I forget. Some terms are Greek, some terms are Latin. This is probably Greek. Mellitus is sweet. That urine is sweet taste. Why is there polyuria in diabetes mellitus? This you should know by now. You know by now, and you have to write. Polyuria and polydipsia are characteristic features, even polyphagia. Characteristic features of diabetes mellitus. Why is there is polyuria? Because glucose is going out. So osmotically water is also going out. Water is being dragged. So water polyuria in diabetes mellitus. And as the body is losing water, so there is thirst mechanisms take over. So there is polydipsia, excessive drinking of water. That is in diabetes mellitus. Is it complete? So what is diabetes insipidus? Insipidus is, the term insipidus is insipid means, so mellitus means sweet taste. Mellitus corresponds to, that means sweet taste. Insipidus is tasteless. So water, here glucose is not going out, water is going out in the absence of ADH. So anything, any pathology, any disease, any mechanism that hampers ADH utilization by kidneys, or ADH itself is not there due to some, where from is ADH secreted? Precursors of vasopressin are formed in the hypothalamus and through the neural connections with the posterior pituitary. Just for revision, What are the connection? What type of connection is between the pituitary hypothalamus and the anterior pituitary? It is vascular connections. That's why the releasing factors which come from the hypothalamus to the anterior pituitary has nothing to do with ADH. We are just revising one or two lines. Posterior connections between the hypothalamus and the anterior pituitary are vascular. That's why release whatever was called factors like gonadotropin releasing hormone, these were called factors. Then corticotropin releasing hormone, thyrotropin releasing hormone, these were earlier called factors. Now these are called hormones. Because it fits the definition of hormones, it is coming through vascular connections carried by the blood to the anterior pituitary. But connection between the hypothalamus and posterior pituitary is neural. So whatever is coming out of the hypothalamus, we are not calling it hypothalamic hormones. Although the precursors of whatever the essential part of this ADH and what is the other posterior pituitary hormone? Oxytocin. These are all formed in the hypothalamus, precursors. Along the neural connections, these are precursors are converted into the active form of the hormone, but they are secreted into the blood only from the posterior pituitary. So these are called as posterior pituitary hormones, oxytocin and ADH. This is just revising endocrine physiology, one or two lines of endocrine physiology. So formed in the hypothalamus, if there is a hypothalamic disease or the pituitary disease, there is a something, any pathology there which hampers ADH formation, that can lead to. So if there is no ADH, there is no question of utilization by ADH. So that is called central diabetes insipidus. Central, it is occurring in the from the center. It is the pathology, the problem is in the issue is in the center. But if there is ADH but the kidneys cannot utilize it, it is called nephrogenic diabetes insipidus. And how does it differ with diabetes mellitus? These two features will match, polyuria, polydipsia, but the causes of polyuria are different. In the absence of ADH, water is not reabsorbed in the late distal tubule collecting ducts, and so water goes out. This is the reason for polyuria in diabetes insipidus, and accompanying there will be polydipsia. But in case of diabetes mellitus, water is osmotically drawn out because glucose is going out. So causes of polyuria in diabetes mellitus and diabetes insipidus are different. But cause of polydipsia is probably same. Central diabetes insipidus, diabetes mellitus, central, and nephrogenic diabetes insipidus. Nephrogenic is ADH is there, but suppose receptors are not there. Any inability of the kidneys to utilize ADH which is actually there. Brain can supply, hypothalamus pituitary can supply the ADH, but kidneys are not being able to utilize it. So whatever may be the cause, polyuria is due to non-utilization or non-existence of ADH, non or less existence of ADH. Nephrogenic versus central. But cause of polyuria in this diabetes insipidus and cause of polyuria in diabetes mellitus is different. So this can itself be an explain why type of question. But polydipsia, same cause. As water, if body is losing water, so thirst mechanisms are activated. Electrolyte balance, we will discuss it to some extent. Electrolyte and water balance and acid base balance and micturition is whatever is left in renal physiology. Micturition, some renal function tests and about renal function tests, and about even they have included dialysis, artificial renal transplantation in your syllabus. So probably questions won't be there that much from those portions, but we will try to touch them in the subsequent classes. But this is reabsorption and secretion. So many, I took maybe 6-7 classes, 6 classes at least. Along with one class was there just revision of clearance and renal blood flow. So 7 classes probably, tubular reabsorption, secretion and urine concentration dilution. Glomerular filtration, reabsorption, secretion, 6 or 7 classes. So 7 hours that is. So that is diabetes insipidus. So what is another type of diabetes insipidus, central and nephrogenic? That is primary polydipsia, which we don't know about. There may be psychogenic causes of primary polydipsia, which is not much known about. So that treatment of diabetes insipidus is something called desmopressin if it is central. So if desmopressin is given, it is just for the sake of, for the time being considered is an artificial ADH, synthetic ADH analog. So if desmopressin is given, it will respond in central or nephrogenic. Just apply your brains. It will be useful in central or nephrogenic. If we give desmopressin from outside, it is synthetic ADH analog. Should it be useful in central or nephrogenic? In nephrogenic, kidneys has lost the power to utilize it. So whatever we give from outside, so that is differentiating. How can we differentiate between, this will be discussed in medicine. How can we differentiate between central, where there is receptor malfunction, whatever we give from outside cannot be utilized. So that will differentiate between central and nephrogenic. If it is nephrogenic, so if desmopressin reveals, if there is no dilute urine is being passed, if there is concentration of urine is not achieved, even after injecting desmopressin, first we consider the symptoms. So where we have diagnosed diabetes insipidus, if it is not responding to desmopressin, it is probably nephrogenic. If it is responding, it is probably central. But even after that, polydipsia may be psychogenic also, and it has nothing to do. ADH is there, everything is there, but the person is drinking more. So there is polyuria. Their polyuria is secondary to polydipsia, and there is something classified as gestational. It happens gestational, again there is the loss of some mechanism, there is some mechanism, unknown mechanism, where loss of utilization of ADH, loss of the power of the bodies to utilize or the kidneys to utilize ADH. It occurs in pregnancy. But psychogenic is, the person is not actually thirsty but drinking a lot of water. So he or she is telling I am thirsty. It is not due to thirst mechanisms, physiological mechanisms in the body, or hypothalamic thirst mechanisms. If they are destroyed, hypothalamus controls, then also there may be primary polydipsia. So this is decreasing. So these are just imaging. See, peeing very frequently during the night, okay, lot of clear pee. Clear pee means free water clearance, and whatever we discussed. Extreme thirst. So arginine vasopressin disorder, diabetes insipidus. These are the causes. Don't need to go into the details. These idiopathic means unknown. Trauma, surgery, whatever happens in hypothalamus or pituitary central, whatever happens due to non-utilization by kidney, that is nephrogenic. And primary is psychogenic illness mainly, or hypothalamic thirst mechanisms are destroyed in some cases. Difference between diabetes mellitus and insipidus. The causes of polyuria in diabetes and mellitus and insipidus are different. So this brings us to end of urine concentration and dilution mechanism.